is the topic for discussion about the pressure injuries in ICU. Thanks to the Indian Society of Critical Care Medicine for giving an opportunity for the Yashoda Hospital for speaking on an important topic about pressure injuries in ICU. Myself, Dr. Madhusudan, I am the critical care in charge at Yashoda Hospital, Secunderabad. My colleague, senior doctor, Dr. Durgesh Satalkar, who is a senior consultant taking care of the neuro-intensive care unit at Yashoda Hospital, Secunderabad. He'll be speaking about the pressure injuries in the ICU. I think every person getting admitted in the hospital, particularly the intensive care unit, and the patient staying more than 3 to 5 days, some or the other form of injuries will happen for the patient, and these are the all preventable one. Now, some of the reasons patient admitted because of some injuries like spinal cord injuries or traumatic brain injuries, where patient cannot move himself, for that require a lot of assistance from the nurses and other things. And how to identify that injuries, how to prevent that injuries, what are their complications and implications. I think Dr. Durgesh will take us through about the pressure injuries in the ICU, and at the end, we'll take about the question answers. I request all the participants in the chat box, we can put your questions and answers, and at the end, we can discuss, or in between, any some issue is there, we can put in the chat box. I'll request Dr. Durgesh or myself to satisfy that query. Thank you. I'll request Dr. Durgesh to go ahead with the presentation.
Thank you, Madhusudan sir. I'll like to thank ISSM giving me opportunity to present the webinar on pressure injuries in the ICU. As we more and more deeply involved in the critical care and ICU, we are now seeing ECMO evolving. We are now seeing different mechanical ventilator strategies are evolving. Prone ventilation is like now established, and now as we go on deeper and deeper and more on the advances, simultaneously we should not forget the basic care of the patient who was admitted to the ICU. Like pressure injuries, they are like commonly happening if we ignore them. So these are the localized soft tissue injuries which develop due to, it's a combination of different forces like prolonged pressure, or there are shear forces or frictional forces. So specifically to the specific areas of the body, especially mainly on bony prominences, where the skin is thin, somewhat other body part. So there are the high chances of pressure injuries might be happening. So previously, this terminology is like we used like decubitus ulcers, bed sores, or pressure ulcers. But nowadays, the National Pressure Ulcer Advisory Panel has released a new terminology. Now, all the injuries now come under the category of pressure injuries. So, all the organization itself has changed from National Pressure Ulcer Advisory Panel to now it has become a National Pressure Injury Advisory Panel. So, where are the areas, or which are the areas are high risk for the development of pressure injuries? So in supine ventilation, supine patient, their occiput region, elbow region, sacral region, buttocks and heels, these are the pressure points where we have to mainly focus to see whether there are development of any ulcer injuries are there or not. Especially nowadays, we are commonly doing a prone mechanical ventilation in ARDS patients. So, and not only this, we have to see other areas like toes, feet of the patient, knee joint, iliac crest, elbows, pressure points, even if ears and cheekbone around the maxilla, there are also areas where we can get a pressure related injuries. So not only in lateral areas, whenever we are keeping the patient in lateral, there are also certain areas which are coming in contact for bed. There are different greater trochanter, ankle joint. There are also they are at risk of development of the pressure related injuries. Certain areas, suppose in lithotomy position also, there are the bony prominences. There are high chances that it will get pressure injuries. So what are the risk factors? What are the causative factors for the causes for pressure related injuries? There can be direct causes and indirect causes. As we know, direct causes will be any pressure, prolonged pressure or particular bony prominences, or frictional forces when the patients like in proper position, they are gliding down. Prolonged immobility of the patients, those patients who are mechanically ventilated, we are given sedation or relaxants. These patients are immobile. These patients are more prone to the development of the pressure injuries. Similarly, diabetic patients or long-standing diabetes patient, they have developed peripheral neuropathy. They have loss of sensation, so they may not sense the abnormal pressure or prolonged pressure. These kind of patients are more prone for development of pressure-related injury. So to begin with, these patients having prolonged diabetes, we have to be more careful or more alert regarding the development of the. We have to scan every day the pressure points multiple times every day, or each duty we have to scan for the pressure points, whether there are any changes are started or developing. Not only these points, there are certain indirect causes. Indirect causes are like poor nutrition of the patients. So elderly patients who are staying at some home shelter, or where there the nutrition is properly not taken care of. In these kind of patients, the bony fat pad has significantly reduced. The skin integrity has significantly reduced. The skin become more vulnerable for the pressure related injuries. Or other patient who is having long standing any heart failure problem or chronic kidney disease problem, or patient having COPD where they are prolonged hypoxia. Prolonged hypoxia, what will give, it will delayed wound healing. So these kind of patients are more prone for the development of the pressure related injuries. Patient is having spinal cord involvement, traumatic brain injury patients, or patient where there is a bowel bladder involvement, frequent incontinent patients. So there are more swelling of the area around the sacrum with the, like probably with the feces or any urinal. These things, these patients are more prone to develop pressure related injury. Uh, Patient having abnormal mental health conditions, they may not tell clearly about related any abnormal sensation, or they may not able to take care of their nutrition properly. They may not able to change the position properly. These kind of patients, these are the certain risk factors in the patient. So we are more prone, these patients are more prone for the pressure related injury. So while taking care of these patients, we have to check all these factors which are present in the patient. So why these pressure related injuries are happening? Basically, if the patient is in particular position for a longer period of their time, so what happens, the capillary perfusion, arterial side capillary perfusion, the pressure will be around 30 to 35 centimeter of water, and the venous on the venous side it will be around 15 to 25 centimeter of water. So prolonged pressure, bony prominences will have a pinching effect of on the vessels, and they will cut off the probably initially on venous circulation, and later on the arterial circulation also. There is localized area of the tissue necrosis will develop, and this tissue necrosis, if not taken care of properly, if you are not changing the position, they may lead to further later on the formation of the ulcers. So not only the tissue ischemia, sir, there are ischemia reperfusion injury as well. So the lymphatic drainage at that particular area is also blocked because of the prolonged pressure also. So there are abnormal immune response also. And as I told earlier, because of the some chronic condition like congestive heart failure or COPD patient, there are prolonged hypoxia. They will cause impairment of the wound healing also. These are also leading to causative factor for the pressure related injury. And there is also called as failure of reactive hyperemia, which is we'll see in say diabetic patient or any other patient who has chronically bedbound. What happens is in normal patient or in normal individual, whenever you are lying in the particular position for a longer period of the time, with the metabolic substrate which are released in the circulation, which will sense to change the position, so that will change from any abnormal position or any non-anatomical position. So the circulation can be restored. So development of ulcers or development of injuries very rare, or it is not happening in the normal individual. On contrary, those patients who are chronically bedbound, who are chronically admitted to the ICU, the reactive hyperemia is not very effective. Even after changing of the position, the color of the, it will take time to change the color to the tissue, the microcirculatory abnormality to come in play, and these patients are more and more prone for the development of the pressure related injuries. So then how to grade these pressure injuries? Traditionally, they has been grading from stage 1 to still stage 4. Stage 1 being mild, and stage 4 means there is a deep involvement. To start with the grading, stage 1 is only a superficial layer, or the epidermal layer of the skin is involved. So there will be non-blanching redness or on the localized area or in the bony prominences, likewise here. So in dark pigmented or may not be having clearly visible areas. So there is a discoloration, there is a warmth, there will be edema. So at this point of time, we should alert that this patient might land up in the pressure injuries, and we should be more alert and we should be more cautious about these kind of these areas of the patients. So in stage two, the involved the superficial epidermis and dermal layer will be involved, but subcutaneous fat is spared. So it is a partial loss of skin, but there is no slough at the base of the ulcers. So now you will see this is the epidermis and dermis is involved, and subcutaneous fat is spared in this. So in stage three, full thickness tissue loss will be there, and subcutaneous fat may be visible, but it is involved. But bones, tendon, and muscles are spared; they are not involved. So there will be slough may be present, but it doesn't obscure the depth of the ulcers. So this is the grade three bed sore or pressure injuries. In grade four relative pressure injury, there is full thickness loss of the skin, including the muscle and bone and tendon. They are exposed. So the some areas of the ulcer may be covered with a slough. So there, this you'll see here the completely bone or complete muscle is exposed. There is a full thickness pressure injury. This pressure injury will again further complicate the ICU stay. Further, there are high chances of infection. Patient may land up in the new form of sepsis is possible. So there are further staging is there unstageable pressure injuries are the full thickness injuries where the base of ulcer is covered with a slough. It may be yellow discoloration, or it may be totally purulent discharge, or it may be brown color. The wound bed is not visible. Here you can see the full thickness, full tissue loss will be there, but the ulcer of the is totally covered with the either black or either purulent slough. The next classification is deep tissue injuries. Here, there are the localized and persistent injuries, which are non-blanchable, and they are maroon discolored, but the skin is intact, or there will be blood-filled blister is there. So it may be due to underlying tissue damage is there, but the superficial skin is intact. You can see like this. There is the skin is intact, but there is underlying discoloration of these things. So then coming to how will you grade or how will you identify which are at risk of the patient? So Braden score has been proposed. So it takes care of total certain components like sensory perception. They are scored from the completely limited to the no impairment. Minimum score is 1, where the patient is sensory perception is totally limited. Patient may be unresponsive patients. So unresponsive to any painful stimulus, there is decreased level of the consciousness. Patient may be having on sedation, or to the totally there is no impairment. Patient is actively responding to the verbal stimulus, and there are no any sensory deficits. So the completely limited is given a score of 1 until 4 is no the impairment. So coming back to second point, the moisture. The wound or skin may become constantly in the moist. So there may be any like patient like dampness will be there around skin every time. So totally, and this is the given as a least score of 1. And rarely moist is skin is usually dry, and there is very less changing is required. So activity, patient who the third point is activity. Patient is totally bed bound patient, or the patient is completely walks frequently. So bed bound patient obviously given a very less point, and patient who are walks frequently, walks out independently taking care of, there are given a maximum 4 point. Coming back to the next point is mobility. Patient who are completely immobile, patient who doesn't take care of, don't change position on their own, or those there are no limitation, so the patient changes his position frequently and without any assistance. So they given as a maximum point of 4. So nutritional component also. Nutritionally, who was very poor, or they are like eating very minimal, so they are kept on only IV fluid. They are orally just they are taking some clear liquids. These patients are definitely obviously nutritionally very poor. They are high risk of developing the pressure related injuries. Till the patient who are they are nutritionally optimized, they take every meal adequately, they taking every either fourth, fifth hourly, whatever the food is being provided, they are taking. This called as nutritionally, they are very well maintained. These patients are very less chances of development of the pressure related injuries. Then again, frictional and shear forces also we have to take care of. Certain patients who are just comatose, just they need a frequent change of the position. They frequent need assistant to change in the position. They are highly prone for a development. Till the patients who are actively moving in the bed, or they are independently sitting on the chair, they are cooperating with the physiotherapy and all. These patients are really has risk for development of the pressure related injury. So to classify the scores, the patient who is having mild risk, they have score of more than 15. Moderate risk score will be in the between 13 to 14, and high risk score will be 10 to 12. And those patients having score of 9 or less, they are high risk of development of the pressure related injuries. This is the Braden score, what we just discussed now. So now what could be the treatment, what could be the strategy we should apply in this taking care of this kind of the patient? So always make sure that the prevention should be your first strategy. Once it is the ulcers or age developed, then it will be a chronic problem for the treating team as well as the patient and himself or herself and the attendants also. So always make sure that we have to reduce the sharing forces. So if you are keeping a proper position, don't just keep a patient bed erect. So there should be slanting. So you should be minimizing the frictional forces. You should be minimizing the gravitational as well as positional frictional forces. Give us such a position to the patient that the frictional forces should be minimized. Bony prominence should be always be taken care of. So we follow here the every second hourly changing the position of the patient. So here like in like almost 8 10 to 12 times we have to change the position in 24 hours, like this shown in this diagram at this particular time. So in between 12 p.m. to 2 p.m. the patient position should be like this. All the pressure points should be well adequately covered. So these are like in between 2 to 4 the patient position should be like this. Likewise round the clock this cycle goes, and in 24 hours all this like particular patient is given a different position, so that at particular point the bony prominences or any, there should not be excessive pressure or there should not be frictional forces. And coming back to how we will should adequately position the patients, though there should be bony prominence should be adequately covered. There should, suppose if you are giving a lateral position, give a adequate pillow or adequate mattress in between the legs. So the here I seen the pillow is given between the pressure points. Always try to cover up the pressure points. So coming back to the, like if lateral position, give a 30-degree lateral position. Again, the you can keep a pillow in between the two legs to avoid the pressure points. So avoid the direct contact of the bony prominences, like heel here. You see the at the calf region we are given the support. So the heel will be not directly in contact with the bed. Or what you can put a saline field or water field hand gloves at the pressure point, so that these will be there very soft and they will not cause pressure related injuries. These are the how we have to locally we have to make the things so that the pressure points will be all adequately pad or covered. So other pressure reducing matrices are also available. These are called as nimbus matrices, where the air is filled and these air cells are interconnected. So they are periodically inflating and deflating. So that what will happen is during this course of the time period, particular at the bony prominence or particular part of the body should not be exposed to the continuous pressure. So this periodically inflating and deflating. So the pressure will be distributed uniformly. This is the bubble mattress also, which we can use commonly. So other rather than preventive, rather than treatment, it is a more of preventive. So I always be in coordination with your dietitian. Optimize this patient nutritionally. Either you can have a weight based or if the patient is having a chart based, all patients should be having fed adequately. So for example, if the particular patient's weight is this much, target adequate protein, say 1 gram per kg body weight had to calculate and you have to give, as well as calorie wise should be also optimally, patient should be optimally fed. So all these stress element, vitamin supplementation should be also adequately given, and we have to take care of the hydration also. So patient should be well hydrated, well nourished. So will further reduce the chances of pressure related injuries. So always early mobilization is the key. Is the mantra. So we have seen, apart from like even in ICMO also, we have now started moving towards more and more mobilization. So if patient is more and more immobile, then obviously the pressure related injuries again happening will be on the more sides. So apart from this, how will take care? How will individualize the care? Like general care should be there. And you can apply a coconut oil or coconut water. Those patients who are in the ICU who are ventilating or giving a prone position, what we usually practice in at our center is, we all those patients who are like totally sedated or paralyzed and on mechanically ventilated, prone ventilation patients are there. So probably pressure points, we covered it with the coconut oil at particular night time, so that the pressure injuries and the frictional forces will be reduced. So that will help or prevent the development of the pressure injuries. So suppose in case debridement is needed, so you can have options of negative pressure wound therapy also, and dedicate a person to see how the progress of the patient. So out of suppose in 10 bed or 12 bed of the ICU, so one nursing in charge or particular nurse should be assigned to check the how many patients are developed with bed sore, and day to day what is the update. We have to keep a record for these, what the what are different stages, whether they are progressing or they are static or they are improving. So and probably some patients might be having chronic neuropathic pain. They may need proper analgesic supports or systemic supports as well. So apart from these preventive strategies, sometimes patient may require wound management in the form of surgical debridement also. Here we have to have involved the other specialties as well. So up to stage one, we should know probably surgical management is not needed. In the up to stage two also, if required, any the minimal debridement will be required. And this kind of, we have to clear all the moist and all. We have to keep as dry as possible the area around the pressure related injuries. So in stage three and stage four, here the these are the deeper injuries we have to take care of for the plastic or surgical opinion. They may plan the debridement of the necrotic tissues, as well as later on grafting also required when the base is completely well adequate granulation tissue will be there. Then we have to plan later on finally skin grafting as well. So there are certain adjunct therapies which are tried in research, but they are exact their utility is questionable. Say like hyperbaric oxygen therapy, which like promote wound healing. Like oxygen is necessary for the wound healing, but hyperbaric oxygen will adequately lead to wound healing or not. That is again a questionable therapy. So in available, if available and all may be tried, but there are very few recommendations for using these kind of strategies like electrical stimulation, topical ultrasound, or topical oxygen therapy. Frankly, these are very limited data available, but I think preventive strategy is the major core of this strategy. Later on, these therapies are very questionable. If at all available, you can use it. So uh, coming back to the this brief lecture, I'd like to have certain MCQs which will discuss and which will further will have a knowledge share basing. Those who are participants, they can post the answers in the comment box.
I think people are posting the answers, sir. Which score used to assess the protection of the bed, sir? I think most of the people posted the answer is almost about 4. Is it correct?
Yeah, yeah, it is a. So as per Braden score, if the score is less than uh, just so the which score is used to assess the prediction of the bed score? Yeah, so the we know that Apache score is used for the scoring of the critically ill patient. Force score is again for neurological cases. GCS is we know. Braden score is used to score the uh, prediction for the bed score, which is the patient is having high risk. So as per Braden score, the what is the score to label it as a patient will high risk for development of the pressure injuries. So yes, it is those who having score of less than 9 is a high risk of development of the pressure related injuries. So the next is what are the causative factors for the development of the pressure related injuries? Either it is a shear forces, frictional forces, or inadequate nutrition, or all of the above. Yes, so Mark post, yeah, as we discussed, the pressure injuries are the combination of the multiple factors. One is like prolonged pressure at particular bony prominences, frictional forces and shear forces with acting, and patients who are probably nutritionally not very optimized. These patients have high risk for development of the pressure related injuries. So the next question is regarding pressure ulcers. What is correct? The pressure injuries are different from the decubitus ulcer. Nutritional has a very minor role to play. All ulcers now injuries are categorized under pressure injuries. Lymphatic obstruction may not be causative factor in development of the pressure source. So nowadays, as we discussed, the pressure injuries, the all the decubitus ulcer, bed sores are now categorized under the heading of pressure injuries in the ICU. So even if the national registry also in Western countries, they now label it as a pressure related injuries also. So all injuries, all ulcers in the ICU which are decubitus are they are now classified as a pressure injuries. So apart from Braden scale, any other risk assessment scale is used for pressure injuries? That is any SOFA score, MPM score, Norton subscale, or AVPU score. Yeah, so Norton subscore is also very commonly used, but mainly is Braden score, but Norton subscore is also used, but keeping the point the same. So the SOFA score and MPM score, we know these are the commonly used to see the sepsis and mortality prediction model. So I'll here conclude the brief topic on the pressure related injuries. So any other point of discussion we'll be opening and we'll be discussing.
Thank you, Durgesh. Some questions are in the chat box. We'll take that questions first. One of the attendees asking about stage 4 pressure injury. What solution to be used for dressing, such as betadine or peroxide or any other particular ointments?
So the with grade 4 pressure injuries usually betadine. I think we are we had to collaborate with our plastic surgery people. So usually pressure grade for pressure related injuries there is like it depend upon the like again the how the ulcer bed. It is like lot of slough is present, unhealthy slough is present, or healthy granulation tissue is present. That depend upon the thing. So I think with the slough, initially we have to clean it with the hydrogen, probably with the hydrogen peroxide or with the betadine clearing, and we have to dry it and we have to give a dressing. So this will be more of a towards a combined approach rather than particularly asking for the. Here we have to take opinion for the more of the plastic people.
One important thing is there, whenever the stage 4 bed sore, it means it is near to the bone and soft tissue. Unless until you remove the dead tissue, wounds won't heal. So that first and foremost about debridement of the tissue is there. That is one. And number two, sometimes this medications we're using, it causes irritation to the skin and sometimes delay the healing of the wound also. So that you have to be very careful. The one line answer is there of the stage 4 bed sore requires a debridement and subsequently about the patient with regular dressing with a normal saline and your T-back ointment, mucosin ointment are there or some hydrogel like things are there that will be sufficient for the patient, I think. Now, next question is Shruti is asking how we control pressure injuries. What is the solution?
So control of the pressure injuries. Look, whenever any patient comes in the ICU, we have to, from the point of entry to, we have to categorize. We have to see certain patients are very high risk factors, like diabetes patient, uh, poorly uncontrolled diabetes, elderly patients. They have particularly peripheral neuropathy. They have loss of sensation in their extremities. These patients have high chances of development of the pressure injuries. These are certain kind of patient. Other kind of patients where patients who are already having, suppose elderly patient, poor nutritional status, patient who are having suppose dementia, they are long standing bedbound patients, or patient who has sustained a stroke or some lower extremity fracture. They came with other problem or encephalopathy or came to the ISO. These set of the patients, they are high risk of developing pressure ulcer. That is the first point. So taking care of this patient wise, we should be not keeping this patient particularly in only one position. So we have to keep on changing. As I showed, there is a dial which follow in our ICU. Almost every second hourly, we have to change the position. We have to take care of every bony prominences which are coming in contact with the bed or which are coming in contact with the surfaces to avoid the first is the frictional forces and all. So this is the one strategy. Other strategies like what we can do, we can smear, can put a coconut oil and all towards the all the body surfaces so that the frictional forces somewhat will minimized. Many times what happens is the patients might be already having some redness or already having grade 1 or grade 2. Suppose you can see commonly when the patients are being shifted from other ICUs or other rehabilitation or nursing care, they have established beds. So we have to minimize the pressure or any form of injury. So many times we cannot keep, suppose a patient has developed sacral ulcer. So we cannot keep on these patients supine for longer time. So we have to keep on changing. So first identification, the second preventive strategies, early frequent change of the position, nutritional optimization, and we have to have a plan of early mobility of these kind of patients also.
I think the answer is not single. The multimodal approach is there, starting from the prevention, changing the position, the nutrition, and the early mobilization is, I think, Dr. Durgesh has told very well. If you follow these 4 or 5 strategies are there that are able to prevent the pressure sores or pressure injuries. One more question is there, Durgesh. If suppose we sleep in a prone position, what are the injuries we'll be getting? So as they put the position. In the prone position, which are the areas we'll get about the injuries, the pressure injuries, and how to prevent them.
So, as now, when we are more of after the Berlin definition, now the prone ventilation is very commonly practiced in severe ARDS patients. So, what we do in actually in prone ventilation, the problem comes in the why prone ventilation is like these patients are sedated and they are like paralyzed. So they are totally immobile. So pressure injuries where it's starting from forehead to maxilla to chin are these chest region as well as elbow, bilateral elbow region, and knee joint, and probably toes also. These are the high risk areas where we can develop the pressure injuries. So actually what happens is we are keeping at least 16 hours of prolonged ventilation. They are coming in contact with the surfaces bed actually. So what we can do, so what to prevent this, actually there is a bolster coming on. So you probably seen in OT, whenever there is a prone surgery in prone position is happening, there is a gel filled bolster will be there. So what will it is very soft, and it will just encircle the forehead as well as bony prominences, and it is very soft and gel like type. So it will have a proper position to fit your endotracheal tube. So you can use this one, so that the pressure over the forehead and subsequent development of the pressure injuries are also limited. So we have to have a, as far as possible, swimmer's position or normal position, where the our both arms are flexed and kept aside at the both of the head side. So you have to adequately pad the elbow joint, keep an adequate amount of gamgee so that they are very will be very soft. Chest is also have anteriorly, you should have a pillow adequately, so that the chest is very well covered, especially in the female. There are high chances of pressure injuries in genitalia as well in breast, and the genitalia should be properly taken care of while giving it. There also should be covered adequately with the padding. Multi-layer of the padding has to be there. Knee joint also adequately supported with the pillows and all, and probably your toes and all. There also have, you can have put a saline field gloves at this time, so that any point of time the pressure at the particular we have to minimize.
I think as you are lying supine, what are the points you're getting touched in the same way for the prone position? As Durgesh has told about the forehead, the nose, the ear, the breast, the genitalia, and the iliac crest and the patella. These are the points that they're causing the pressure injuries. And I think you have to take an adequate precautions, as your Durgesh has told about putting a padding. That will be better. One more question here, Durgesh, about if the grade 4 injury, what are for the supine position? And what will be the problem, you can explain as you told, sir. It means what he want to ask me. The thing is that with the patient having sacral gluteal injury, we cannot give supine position. What other positions are you can suggest for the patient for helping for improvement of the gluteal or sacral bed sore?
So for the sacral bed sore, so obviously we cannot keep these patients for supine for first basically avoid the supine position. So as far as possible, we have to give a lateral, we have to keep changing on lateral position every time. So obviously many times like a supine position, but we cannot keep it like for longer period of the time. Ideally we should be changing every second hourly position of the patient. So like sacral bed sore, again it will be definitely a challenge. So we have to keep at either lateral position for at least maybe for a prolonged period of time, maybe instead of two, maybe 3 hours. And supine position, I think more than like even if 1 hour also will be very risky. So obviously the bed grade 4 beds or a sacral leisure is definitely a nightmare for the nurses to take care of. The only solution available is to further we have to prevent it. Further prevent it, we have to reduce the pressure at that particular point. And the options are available are extremely limited. You have to just keep on changing lateral position and with the minimal supine position.
Yes, absolutely correct. The thing is that if the patients are mobile, we can mobilize in the wheelchair, and changing the position regularly is important. And I think previously he told about debridement, putting a negative pressure dressing for the patient will help for the rapid recovery of the patient. Now, one more question is there: if the grade 4 injury, what are the for supine position? What will be the problems? Can explain? I think he told already. He was asking about the Veplex dressing with the helper, and if the stage of Veplex injury done in hand, with what kind of solutions we use. Here they are asking about some dressing is there by name Veplex dressing. Will be any helpful for the grade 4 bed sore?
Maples, like even like further going for any other particular dressing, the grade 4 injuries are basically it is a not particularly we have to limit it. It should be multidisciplinary team approach. So we have to first thing is that for to grade 4 ulcer to heal, so we have to have at the base of the ulcer or has to be totally properly have a healthy granulation tissue. So we have to have a proper debridement. Then we are in tune with the other surgical colleagues. We should be having, if any discharge will be there, negative pressure system will be helpful. Maplex dressing is, I think, not very much of experience using directly in grade 4. So I think grade 4 is the probably, if base is adequate, healthy granulation tissue, we should be having direct. Have a first option will be, if it is possible, we have to discuss with the plastic surgery our colleague whether the grafting is possible or not. The grafting is not possible, then I think Maplex dressing can be tried, but very limited success. Or I think we have to keep this dry gauze dressing will be, I think, maybe an option.
Yes, as I told that, see, when you talk about the grade 4 bed sore, this patient is having there, then no dressing going to be helpful for the patient. Debridement, surgery, and the wound care is much more important for that one. I think this the questions via the chat box. Still, if anybody is having questions, they can post in the chat box also. I think I thanks Durgesh for taking a very important topic about the intensive care medicine, about the pressure injuries in the ICU. I think is one of the important thing is there about the one of the quality indicator in the ICU is about the pressure source or pressure injuries in the ICU. In most of the hospitals we follow is mandatory for keep a record of all things in NABH and JCI. And important thing is there about the because of the pressure injuries will increasing the morbidity and sometimes even mortality also in a long run of life. So that prevention is better than cure. So that you take the precautions when the patient entered. Once you done stabilization, the next your all attempts should be there for preventing the bed sores. I thank Dr. Durgesh talking about elaborately, and I think you are quite interesting about the last point about the MCQs. A lot of people enthusiastically participated, and I think most of the people given a correct answer that indicate that most of the people understood whatever you spoke. With this, I thank to the ISCCM for giving an opportunity for us, particularly the Yashoda Hospital, myself, and Dr. Durgesh to speak about the important topic about the pressure injuries.